I've lots of conflicts of interest. I'm just speaking as myself today as opposed to representing any of these organisations. I suppose Ireland has quite a pedigree in out-of-hospital cardiac arrest. Frank Pantridge in Belfast was responsible for the first pre-hospital defibrillation in the world back in the 60s, and he had 15 months of data, 10 cases of VF and 5 survivors. And by any measure, even looking at Martin's data there, he was pretty good, 50% survival rate. Now, he's probably going to a fairly select group of cases. In Dublin, a little bit later on, we were responsible for the first non-physician out-of-hospital defibrillation in the world. So, in fact, the first responders were Irish. So it's very fitting that we'll be here. And in the first 3 years of data they had, they attended 2,500 cases. 164 of them were cardiac arrest, 20 VF, 17 survivors, 11 of whom did well. Again, they were pretty good. And it's not that we're getting worse, we're just going to more calls. Again, they were going to a fairly small subset in the middle of Dublin. So people know that defibrillation works. We know that it saves lives. That's why Bridget's doing what she's doing, and that's what Martin's data proves. So we know that it works. But what framework governs that? Well, in Ireland, we're governed by the PHECC CFR standard, which pretty much everybody here is trained to. So that's CPR, defibrillation, choking, chest pain recognition, aspirin, and the recovery position. For those of us who are healthcare professionals, the CFR standard includes oxygen, airway, and BVM according to your grade. And there is a new standard for nominated organisations, and I don't think it's anticipated that this will be widespread for CFR groups, but for certain things like schools or organisations working with certain groups of patients who might be in requirement of one of the additional medications like adrenaline, GTN, Entonox, salbutamol, and a couple of others. So people ask, you know, what should CFRs be going to? And currently the National Ambulance Service sends CFRs obviously to cases of cardiac arrest and choking, and if you're a CFR enhanced scheme, you also go to chest pains and stroke. And it's been thus for a number of years, and it's been one of the questions that we've been asked a lot. Why can't we go to something else? Why did we miss that arrest? And there's good reasons for a lot of that, but I suppose it is perhaps appropriate that we'd have a little think about what CFRs should be going to. So CFR enhanced schemes go to a slightly increased range of calls, and up until recently they brought oxygen. And I'm not going to talk about oxygen today, but I think that does set the scene for some of it. But maybe the best thing to do is to look at the evidence. And the evidence for what we do in terms of cardiac arrest is pretty overwhelming. These are the numbers of patients you need to treat with each of these interventions to save a life. So if you defibrillate somebody, well, actually, if you defibrillate them straight away, you probably only need to treat one patient. But out of about every 2.5 patients who get pre-hospital defibrillation, one will survive. So that's a really good intervention. All the other Gucci stuff, thrombolysis, clot-busting drugs, going to the cath lab, aspirin, CPR without defibrillation, and something that we gave up on a while ago, therapeutic hypothermia, they actually aren't as effective. So we've got a really effective intervention, and it's appropriate that we focus on that. And some of the talks you'll see later are about how we can cut down that time further, because the quicker you get there, the more effective it's going to be. So we know that works. There was a capacity review of the National Ambulance Service, a big document that goes into lots of detail about lots of things. One recommendation of it was that we would consider looking at what extra Delta calls NAS might dispatch CFRs to. Martin will tell me, there's probably 1,200 AMPDS codes, something like that. There's 100. So when you get a 9 Echo 1 call for cardiac arrest, that is one type of call. But there's another 1,000 or so out there that it could have been classified as. So obviously, CFRs can't go to all of them, nor should they. But there probably are a couple that is worth picking out. So that's currently what CFRs will be dispatched to. So any form of cardiac arrest, including cardiac arrest due to hanging, strangulation, drowning, and so forth. And that's appropriate. You also, if you're a CFR enhanced scheme, go to 10 Charlie and 10 Delta calls, which are chest pains. And it's important to get there in case they go into cardiac arrest, and also you can administer some aspirin. But in fact, they don't arrest that often. Most 10 Charlie and 10 Delta calls don't arrest in your presence. Some do, and obviously they're the crucial ones to have CFRs at. There are other calls, and I'm only going to just mention a couple here. The 9 Delta calls, 9 Delta 1 is a cardiac arrest with some breathing, which is perhaps an oxymoron, but that is perhaps a call that CFRs should be going to in case it is a full arrest. And the 31 delta calls are patients who are unconscious, and 31 delta 1 is unconscious, not breathing, which is effectively a cardiac arrest or just about to become a cardiac arrest. And in the Wicklow area for the last year or so, we've been going to those calls as a pilot study. And I think the experience has been good. I don't know if we have any data to say that we've definitely had a ROSC out of it, but certainly we've got some experience for that. And Cathal O'Donnell can't be here today, but I think we've committed to looking at that and seeing what out of those calls CFRs could potentially go to on a more national basis with the current training, because that's perhaps the difficulty. That there are benefits perhaps to going to these calls. For some schemes that includes maintaining interest, because for a quiet scheme who gets called out once a month, it's difficult to keep people motivated. There's a mixture of being too quiet, too busy, and just right, and that's different for every scheme. There are busy schemes here, Bray, Arklow, Cork City, who are going out nearly every day and sometimes twice a day, and that works for them. But that's not going to work for every scheme. And people do this for lots of reasons. They do it because they're interested, they do it to be busy, and they do it to help. And I suppose that's what we're really interested in, is improving the quality of care that we give patients and perhaps the outcomes that people are going to get from it. But there's challenges with that too. It's not straightforward. So schemes are different. So some schemes are large numbers of people, they're busy, and they've lots of spare time, and they're happy to be going to loads of calls. And some schemes are a small group of people who are maybe only covering nighttime, who maybe aren't able to be out every night of the week. And they don't want to be busier. They want to focus on the high-end calls where there's definitely a cardiac arrest, and that's okay. But if you expand the range of calls that people go to, you've got to potentially provide additional training. And training takes time, it takes money, it takes organization, and it's not perhaps something that we can roll out everywhere straight away. And if you train, you've got to maintain skills. So every little extra step that we take has a cost in terms of time and energy that we need to look at. So it's not a case of yes or no. There is some stuff to think about. And there is a reasonable limit to what you can expect lay first responders to do. And I know in this room we have people who are a mixture of both. We have plenty of CFRs who have a professional qualification or job in healthcare or EMS, but many don't. And that's the majority. And you can't expect lay responders to deal with trauma. You can't expect them to go into situations which have patients who have severe behavioral disturbance. And there is a limit to the training technology that we can bring to bear that. So I think we need to be realistic. But there is a national skills matrix. We slot into that. That's the PHECC skills matrix. So CFRs are part of a common pathway from CFR through to EFR, EMT, paramedic and AP. So you slot into that, and we have common CPGs. So it's actually potentially easier here than in many other jurisdictions to look at that. And if you look at the framework which we signed not even an hour ago, one of our objectives is that we will look at increasing the range of response. And I don't know what the outcome of that will be, but I think we need to look at it. And we need to review the range of calls that CFRs go to. And in fact, if you're starting again, you mightn't start with what we have now. You might pick different ones. But that needs to be done on a careful basis, reflecting the training that CFRs have and the risk to them and the patient. And perhaps to regularly review it is the key thing. And CFRs have been in existence since 2004 in Ireland. So we're into our 13th year. And it is, I think, time when there's 450 of you here today, and we have such support from all our professional partners, to look at that, and perhaps by Respond 2018, we'll be going to a slightly different call set with the objective of saving more lives. So something to think about, no definite answers yet. Thanks.